Good morning. My name is Anthony Jones. I'm a PGY3 resident at Medical College of Wisconsin, and today I will be presenting a demonstration of utility and analysis of posterior subcapsular cataracts on optos imaging in retinitis pigmentosa patients. I'd like to give a special thanks to Dr. Thomas Connor and Dr. Jeffrey Wilkes for their assistance on this presentation. In brief, retinitis pigmentosa is an inherited group of retinal disorders. They cause progressive rotten cone degeneration with gradual nyctalopia and progressive field loss. It is the most common inherited disease of the retina. Now, looking at visual field patterns in RP patients, they typically display patchy loss of peripheral vision, evolving ring scotomas, and very constricted tunnel vision. Next, we look at cataracts in RP patients, which often form early. We will be focusing on PSC cataracts, which are the most common morphologic variant within this population, with a 41 to 53% frequency. These cataracts typically involve the central posterior region of the lens and occupy the visual axis. Putting these factors together, we can see even a small central PSC cataract can have a significant visual impact on RP patients. We'd also like to point out that these are treatable causes of secondary vision loss in RP, which is an otherwise currently untreatable condition. This brings us to the Optos Wide Field Imaging System, which at our institution's Inherited Retinal Disease Clinic is used as a standard diagnostic tool to track fundus changes over time in RP patients. Observation was made with regards to an incidental opacity that was commonly encountered and was initially regarded as artifact. With acquisition of more of these photos, it was noted that the opacity is correlated to the size and shape of PSC cataracts as seen on slit lamp exam. An example of such an opacity can be appreciated here on the photo on the right. Taking our observation and performing a lit review on similar findings, one article in particular stands out. This was a study from the Korean Journal of Ophthalmology in which they graded cataracts using a classification system they developed and assessed their impact on accuracy of OCT measurements. They showed that cataract grade based on wide-field fundus imaging was positively correlated with grade of PSC, but not with nuclear sclerosis or cortical cataracts. When asking why PSCs are so much more noticeable on optos images, we can see that the ellipsoid mirror causes a collection of rays near the posterior lens. This then produces the dramatic opacifications on the final panoramic images. Ultimately, we hope to exploit this vulnerability in the optos system. Combining all of the factors we have covered thus far, our question then becomes, can analysis of PSC cataracts on optos wide-field fundus imaging in RP patients demonstrate clinical utility in the medical decision-making? In brief, this is a retrospective series with our inclusion criteria including RP patients with visible PSCs on optos images and who have undergone cataract removal. Below is some of our data acquisition. Overall, 20 patients were included with a total of 39 eyes. All 39 eyes had PSC cataracts, 15 eyes had PSC only, and 24 were mixed cataracts, with 21 having NS cataracts and 7 having anterior cortical cataracts. Here you can also see the grade range as well as the average grade, which was determined by slit lamp exam. Focusing on the average cataract grade in our series, we highlight an example of one that fell close to this range. You can really appreciate the stellate opacification in the central part of this image. The average age of cataract extraction of patients in our series was 46.5 years old, with a range of 20 to 72 years of age. Quickly going over visual acuity, the average pre-op visual acuity was 2300 with a range of 20/20 to LP vision, and the average post-op visual acuity was 2100 with a range of 20/20 to LP vision. This makes the average change in visual acuity 2.38 lines with a range of 0 to 8 lines. 5 eyes showed no change between pre- and post-op visual acuity, and 34 eyes showed improvement within a 6-month post-op window. 20 visual fields were included in this series. All eyes had some visual field constriction, and the range was 40 degrees to 5 degrees of remaining visual field, with the average being 14.38 degrees. When considering an Amsler grid, which tests the central 20 degrees of vision with each half centimeter square representing 1 degree of visual field, we see that an overlay of our 14.38 degrees encompasses this area of the Amsler grid. And here is the same concept overlaid on a Humphrey visual field 24-2. We reviewed 112 Optos wide field images from 39 eyes. This was over roughly a 10-year span. The general observation was enlargement of the obscuration on the Optos images over time. These generally correlated to the exam descriptions of PSCs, and generally the increased opacification correlated with decreased visual acuity as well as decreased subjective vision. Highlighting an example of this correlation, we have two Optos images from the same patient showing stellate obscurations OU. And clinically, they had a 1+ stellate PSC with visual acuity in the 2150 range. The patient was offered cataract surgery but declined. This is the same patient 3 years later. We can clearly see enlargement and increased opacification of the stellate pattern. We note the PSC is now graded as a 2+ stellate PSC OU, and that the visual acuity has declined to hand motion. This brings us to our next concept on how we incorporate perimetry into the analysis of the PSC cataracts as seen on the Optos images. Several past studies involving glaucoma have overlaid visual field information on fundus images, as can be seen here. This study shows that a Humphrey visual field 30-2 encompasses an area about 1 disc diameter nasal to the nerve, and then extends a fair amount outside of the vascular arcades. This study shows that a Humphrey visual field 24-2 encompasses an area just outside the vascular arcades and just nasal to the optic nerve. Lastly, this study shows that a Humphrey visual field 10-2 encompasses an area entirely within the central macula and fovea. Incorporating these concepts into Optos images, we see that a 30-2 lies approximately within this area, a 24-2 within this one, and finally we add the 10-2. Other considerations in the analysis of these photos includes image quality, such as this one, which is excellent, the description of opacification, such as focal shadowing, as we see here, the location of the obscuration, such as the fovea in this example, as well as the density of the obscuration. Here we could say complete. Lastly, we would consider the size of the obscuration based off the patient's remaining visual field. For instance, if this patient had a remaining field of 10 degrees, represented by the red line, we would say this was obscuring approximately 25%. Moving on, we demonstrate an example of a small central PSC, which can clearly be seen as this obscuration overlying the macula in this image. Factoring in our other considerations, we see that the patient's remaining visual field is approximately 15 degrees, which lies somewhere between these two lines. Their visual acuity was 20/70-3, and clinically they had a 2+ central PSC. The image quality here is excellent. It shows focal shadowing of the macula and fovea with near complete obscuration. The area of remaining visual field obscured would be roughly 10 to 15%. Here we see the same eye 2 years later, status post phaco PCIOL, and the vision has improved from 20/70 to 20/50. This is a side-by-side comparison highlighting the contrast between the central opacity of the PSC cataract and the clear view of the macula and fovea status post-cataract extraction. Expanding on this demonstration, we show an example of a PSC transformation over time. We start with a patient who has a remaining visual field of approximately 15 degrees and clinically a trace PSC. This can be correlated to the small central smudges seen here in the superior macula. Now, approximately 2 years later, the patient has a 1+ PSC on slit lamp exam, and we can see enlargement of the small obscurations from the prior image. Nearly 4 years later, the clinical grade is now a 2+ PSC, and we can really appreciate the enlargement of the stellate obscuration on the image. Once again, we show a side-by-side comparison, status post phaco PCIOL. You can really appreciate the precipitous drop in visual acuity, as well as the improvement in visual acuity after cataract extraction. Bringing your attention to the time frame of these images, we see that they were obtained over a 6-year span. Also note that the visual acuity status post-cataract extraction was an improvement from that of the initial image showing a trace PSC. To recap, we have brought to light our observations in RP patients regarding the correlation between these incidental obscurations on Optos images with the clinical descriptions of PSC cataracts. We demonstrated a systematic approach to the analysis of these images, as well as how to incorporate the limited visual field of the patient. Lastly, we stressed the importance of considering all of these factors when analyzing secondary causes of vision loss, especially when they are treatable. Moving on, when considering the technology behind the Optos, which is an SLO system, we encounter the question of whether we are introducing inaccuracy in the relationship of the apparent size of the cataract with the surrounding anatomy. Whether this is true and to what degree, it's difficult to know because there's limited data on the true optics of the system, as this information is likely proprietary. However, we do feel we adequately demonstrated the utility in qualitative comparisons over time, as well as through systematic analysis of measurable obscurations of the underlying retinal anatomy. Taking a step back from this advanced technology, we can remind ourselves that the retinoscope, although highly underutilized, is an invaluable tool in the clinical assessment of media opacities such as PSC cataracts. Used in conjunction with the demonstration here, we can add more information to our decision-making tree, such as the diminishment of the red reflex. With that said, there is value in obtaining Optos images in that they offer details regarding shape and size, they can track changes over time, and it is a powerful teaching aid for patients. Other limitations to consider include the natural progression of RP and the difficulty of tracking multiple dynamic factors such as decreasing fields, worsening cataracts, fluctuations in level of CME, and the development of epiretinal membranes. All of these factors confound the visual acuity data, which adds difficulty to clinical decision-making, but this reinforces the importance of having as much data as possible when formulating a plan for this unique population. Lastly, we have a small sample of cherry-picked cases that showcase our thought process. In conclusion, we hope we have increased your understanding of how debilitating even small PSC cataracts can be in RP patients. Furthermore, we hope it has given you the ability to utilize similar images showing PSC cataracts as objective data points rather than disregarding them as artifacts. Moving forward, we will have a larger inclusion group. We also hope to modify it from a retrospective study to a prospective one.